all set to start this morning session of our first state conference. It's a hectic session. We have a lot of academic lectures, symposiums lined up. So without any further delay, we'll start the first session, which is the podium paper session, in which we have 6 paper presentations. I hand over the mic to both our chairpersons for this session, Dr. Sarang Kanekar and Dr. Madhuja Savekar. Dr. Sarang, Dr. Madhuja can take over to start the session.
Good morning, respected teachers. With no further delay, may I request Dr. Aram to start with his presentation. Please stick to the time of 8 minutes. And Dr. Aram will be talking about study of 61 consecutive cases of fracture penis at Goa Urological.
Very good morning to respected members of the dais, respected senior teachers, my colleagues, friends. I am Dr. Muhammad Arhamati, from Senior Resident from Department of Urology, Goa Medical College, here to present my study of 61 consecutive cases of fracture penis at Goa Medical College. Penile fracture is a traumatic rupture of the tunica albuginea with subsequent hematoma formation. It occurs only in an erect penis with common modes of injury including vaginal intercourse, abnormal bending of the penis during masturbation, forceful efforts to elicit detumescence and external blunt trauma. Patient typically hears a snapping sound associated with pain and rapid detumescence followed by penile deviation to the opposite side of the injury. Ultrasound can help easily diagnose large clinical disruptions, however small tests can be difficult to find. Our aim of the study was to study the clinical presentations, etiological factors, time of reporting to the hospital and management of fracture penis. This is a retrospective observation study of 61 cases of fracture penis which presented to Urology Department in Goa Medical College from May 2012 to June 2024. Clinically, patients were assessed for penile swelling, ecchymosis, any penile deformities, penile deviation, hematoma, presence of blood at the urethral meatus to rule out urethral injuries, patients having any voiding difficulties, any urinary retention. Penile ultrasound was done in all the patients. Patients were taken up for immediate surgical exploration and subsequently followed up at 1 month, 3rd month and 6 months post-operatively. These are some of the surgical photos. The first photo shows the classical eggplant deformity. In the second photo, we have taken a circumferential coronal circumcisional incision, followed by degloving of the penis, which exposes the hematoma. Draining of the hematoma exposes the underlying disruption in the tunica, which was closed using a continuous absorbable Weichel 2-0 suture. The closure of the incision in our institution, we accompanied with a circumcision at the same. Results. Out of 61 patients, the majority of the patients were between the age of 16 to 45 years of group. More than 3 patients were above the age of 46 years. 66% of patients had presented within 8 hours. 33% patients presented between 8 to 24 hours and 3 patients had presented after 24 hours. The most common mode of injury that was elicited in our study was during masturbation, that was 53.3%. Second most common cause was sexual intercourse, around 40%. And hitting of erect penis against a hard object was seen in 5 patients. Ultrasound was successful in detecting the tear in around 85% of cases. At 3 months post-operative, 22 patients had normal erectile function, 9 patients complained of painful erection, 5 patients had an abnormal curvature of penis, and 9 patients had erectile dysfunction. 6 patients who initially had painful erection were improved at 3rd months, and 10 patients were lost to follow-up. At 6 months post-operatively, 28 patients had normal erectile function, constituting 45% of the cases. 6 patients complained of painful erection, 4 patients had abnormal curvature of penis, and 7 patients, that is 9% of the patients, had erectile dysfunction. 3 patients who initially had painful erection at 3rd month had improved by 6 months, and 1 patient underwent corrective surgery for curvature. 16 patients were lost to follow-up. Among the ED patients, comparing age groups, there was 1 patient in the age group of 15 to 30, 4 patients between the age of 30 to 45 years of age group, and 2 patients above the age of 45 years. In seeing comparing time of presentation, All three patients who had presented after 24 hours had erectile dysfunction, and 4 patients who had presented between 8 to 24 hours, and none of the patients who had presented within 8 hours had erectile dysfunction. Out of these 7 patients, 5 patients had mild erectile dysfunction with a mean IEFI score of 18. 2 patients had a mild to moderate ED with a mean score of 14, and none of the patients had severe erectile dysfunction. Discussion. Injuries to the flaccid penis are uncommon because of this protected location relative mobility. In the tumescent state, the tunica albuginea thins down from 2 mm to 0.25 mm, making it more susceptible to traumatic injury. A normal pressure inside the erect penis is the mean arterial pressure of 100 mm mercury. The intracorporeal pressure needed for rupture is more than 1500 mm of mercury. Penile fracture remains a clinical diagnosis. Patient present with swelling, deformity, discoloration and deviation of the penile shaft. If the hematoma is contained within the buccal fascia, often a palpable clot can be felt directly over the tear. However, if the buccal fascia is disrupted, the blood will extravasate into the subcutaneous vein of the scrotum, perineum, pubic areas, resulting in significant swelling. Concomitant urethral injuries have been reported up to 3% of cases. In our study, none of the patients had a urethral injury. Blood at meatus is the commonest sign, and if present, an RG was advocated to exclude urethral injury prior to repair. Current standard of care is immediate surgical repair, resulting in more than 90% of patients having normal sexual intercourse after surgery. The most concerning complication of penile fracture has been sexual dysfunction. However, fortunately, most are limited to the immediate post-operative period. In our study, at 6-month follow-up, 7 patients, that is 11% patients, had persistent erectile dysfunction. 6 patients had painful erection, and 4 patients had abnormal curvature, and 1 patient requires surgical correction. Other complications which have been mentioned in literature include plaque formations, infections, reoperations, urethral stricture, aneurysms, wound edema, and urinary disorders. In a study of 33 cases managed surgically by Ahmed et al. At 6 months follow-up in their study, which was published in the Journal of Sexual Medicine in 2008, 2 cases had complained of mild erectile dysfunction. Penile nodule was found to be the most common complication. 3 patients said that they had mild penile curvature not interfering with sexual intercourse. Painful erection was stated by 24 out of 30 patients in the first month, 7 out of 28 patients in the second month, and it was absent after the third month. In a review of preoperative evaluation surgical technique by Siamak et al., which was published in British Journal of Urology in 2008, they advocated that penile fracture is best treated with immediate surgical exploration. If a urethral injury is suspected, a flexible cystoscopy is recommended over an RGU in the operating room because in such cases an RGU can lead to false results. If a concomitant urethral injury is found during surgery and has been repaired, a subdartus flap is recommended by them to be placed between the corpora cavernosa and spongiosum to prevent further fistula formation. Another study by Norton and al., who published a series of 11 patients over a period of 10 years, they found that 9 out of 11 patients, that is 81% of patients, had preserved normal erections post-op, and 2 patients, however, required the starting of phosphodiesterase inhibitors. Silva et al. In their study, retrospective analysis of 69 patients between 2007 and 2022 found that penile deformation was the most common complication, 14.5%, and erectile dysfunction was found at 5.8%. I would like to conclude by saying that penile fracture is a urological emergency that can have devastating psychological consequences. Diagnosis of penile fracture can usually be made solely on clinical grounds. Ultrasound, however, is a good radiological picture. Early surgical intervention is mandatory in all the cases to achieve good cosmetic and functional results with preservation of erectile function. Thank you.
Any roles of MRI for fracture? Any instances where you have to do MRI scan?
We did not do an MRI kind of thing. Clinical diagnosis, and even if sometimes ultrasound did not pick up based on clinical diagnosis and history and local examination, most of the patients we were able to find. We took up for surgery, and as of now it's not happened that we have not found a gap.
Any of your patients complain about the suture knot or the stitch bothering them later on?
So we use vical suture the first 2 months. We usually advocate patients to start sexual activity at 6 weeks. So sometimes yes, like 2 or 3 patients had complained, but after 3rd months, not many patients had complained of any knots. So 1 patient, however, did have a complaint of a nodule that he felt, but small at first.
did you use any medications to kind of like inhibit the erections in the healing phase?
No, sir, we did not. So mostly we have found that the pain of the surgery and the psychological impact of trauma is so severe that patients usually do not have erection, at least for the first 14 days at least. And we advise abstinence for at least 6 weeks.
Thank you. Any questions from the audience?
Your surgical intervention
Yes, sir.
was on. Your surgical intervention was only restricted to the evacuation of the hematoma and the repair of the
Yes, sir. We did not have any, fortunately we did not have any tear in the spongiosum and no urethral injuries in the study.
no vascular injury. I mean, where you have to repair, otherwise.
No, sir. Only the corporate cavernous.
What do you think may be the cause of erectile dysfunction post your treatment of flexible penis?
So the integrity of the tunica. So actually many factors can. First is the most important factor is the time of presentation. Patients who present after 24 hours, they can have a necrosis, a lot of edema is there, and ischemia is there, sir. Because of its post repair, the leak side, the integrity of your repair can be a little bit compromised. So that is one reason for the erectile dysfunction. Patients who are older patients, they can have intrinsic ED, which is aggravated by your repair. The thing is that if you don't do a watertight repair, if you don't apply a tourniquet and check your repair afterwards, your repair could be a little compromised. So those are the common causes of ED after fracture.
Thank you, Dr. Arnab. I now request the next speaker, Dr. Mahendra Biradar, to come to the dais. He'll be talking on factors predicting outcome in patients with obstructive anuria.
Good morning, Chairperson, teachers, consultant and colleagues. Here I am presenting a study on factors predicting outcome in patients with obstructive anuria presented to Goa Medical College. Anuria is defined as urine output of less than 100 ml over 24 hours. Obstructive anuria is due to upper tract obstruction. Management include resuscitation and urgent relief of obstruction. Our aim was to study factors predicting outcome of the patients with obstructive anuria. In this study, we have included 55 patients presented to Goa Medical College with history of obstructive anuria presenting between May 2022 to April 2024 with exclusion criteria being prior CKD status. All patients were evaluated with history, clinical examination and investigation, that is CBC, RFT and ABG, and radiological investigation being sonography and non-contrast CT. Need for dialysis was decided by clinical status and blood chemistry. Urinary drainage done by percutaneous nephrostomy or ureteric stenting. The factors studied were age, duration of anuria, previous history of calculous disease, comorbid condition, hemoglobin, WBC count, serum creatinine, hyperkalemia, acidosis, urine culture, presence of sepsis, need for dialysis and post-op diuresis. In our study, we found most of the patients being between 41 to 80 years age with female predominance. 30 patients of our study presented after 48 hours of symptoms. With respect to the etiology, we found that there were 40 patients with calculous disease, 13 patients with the malignancy and 2 patients were there with retroperitoneal fibrosis. Among the calculous disease patients, 21 patients were with bilateral ureteric calculi, 8 patients with bilateral PUJ calculi, 6 patients with PUJ with ureteric calculi, and there were 5 patients who were having a solitary kidney with ureteric calculi. In patients of malignancy, there were 7 patients of CA cervix, 4 patients of CA rectum and 2 patients of CA endometrium. Out of 55 patients, 37 patients were treated with DJ stenting and 18 patients required PCN insertion. Most of the patients with the malignancy required PCN insertion and with the calculous disease patient managed by the DJ stenting. Out of the 55 patients, 39 patients recovered with normal serum creatinine after treatment. but 16 patients remain with a higher serum creatinine values. In our study, we found that as a patient with more than 60-year age, more than 50% patient remain with a higher serum creatinine value in spite of the treatment, which suggests of significant association with the age. The risk of developing CKD is 12 times more when age is more than 60. 30 patients who presented more than 48 hours after the symptoms, 13 patients remained with CKD status, which was statistically significant. Prior history of calculous disease was not found statistically significant in our study. There were 24 patients who were diabetic. Out of them, 10 remained with a higher serum creatinine value. 30 patients who were hypertensive. Out of them, 12 remained with a higher serum creatinine value. In our study, there was no significant association of either of two comorbid conditions with development of CKD. There were 10 patients who were having a less than 12 gram of hemoglobin. Out of them, 8 remained with CKD status, which was statistically significant. WBC count was not found statistically significant in our study. There were 13 patients who presented with a hyperkalemia. More than 50% of them remained with a CKD status, which was statistically significant. There were 32 patients who presented with acidosis and 9 remained with higher serum creatinine value in spite of treatment, which was not statistically significant. There were 26 patients who had positive culture on presentation and 12 remained with CKD status, which was statistically significant. Along with that, 29 patients were with sepsis, 13 remained with CKD status, which was also statistically significant. There were 30 patients who required dialysis pre-op and 13 remained with a higher serum creatinine value in spite of treatment, which was statistically significant. With respect to the post-op diuresis, 13 patients didn't have diuresis and 10 remained with a CKD status. 42 patients who had post-op diuresis, only 6 remained with a higher serum creatinine values. There was significant association of post-op diuresis. We have also found that when there is a post-op diuresis, there is 76.3% chances that patient will not develop CKD status. Among all these factors, age was found to be statistically significant by multivariate analysis. These are the presentations of various. Anuria is a urological emergency. When there is an obstructive pattern, there is an increase in intrapelvic pressure which can cause renal damage. Emergency treatment of the obstructive anuria depends on urinary diversion, either by digestion or percutaneous nephrostomy. Definitive treatment to be carried out depending upon the etiology. Management of the post-op diuresis to maintain fluid electrolyte balance is extremely important for the better outcome. PCN is preferred over degestenting in pelvic malignancy and critically ill patients. A study by Rashid Khan suggests oliguria, level of urea, creatinine, potassium were found to be significant poor prognostic predictor on univariate analysis. Another study by Amrullah says prompt and early intervention can save the life of the patient and prevent development of the chronic renal failure. For concluding, age, duration of anuria, hemoglobin level, hyperkalemia, and positive urine culture were found to be poor prognostic factors. On multivariate analysis, age was found to be only significant independent prognostic factor. In patients with post-op diuresis, there is 76.3% possibility of patient not developing CKD. The risk of developing CKD is 12 times more when the age is more than 60. Thank you.
Dr. Mahen, what are the CK, when you write that CKD, what is the CKD stage of those patients that you are discussing? because most of the patients who come nowadays will be CKD1, CKD2. That is not considered really significant for this. So when you say a patient was CKD after your anemia was clear, what CKD stage were those patients?
Patient
And how did you calculate the CKD status of the patient?
in our study, we have already excluded the patient who had prior CKD status. The patient who developed CKD, those most of them we have graded according to EGFR map there. So most of them were CKD 2, 3, but few of them were CKD 5 also, who had a higher age. Those two patients were with the age of 80. So they remain with the higher serum creatinine values persistent.
Why I'm asking this is because all your values will differ for CKD. Whatever association you have found will differ for different CKD statuses. Those associations will be different for different CKD status. They will be much higher for the higher CKD statuses, whereas hardly anything for the lower CKD status.
It's interesting when you say that. First of all, you said there is no previous history of CKD. Now, many of them would have come for the first time. So, how do you judge unless they have a previous record of their creatinine or any investigations done in the past? So, to really judge whether they all had previous CKD and this is acute on chronic disease becomes difficult in emergency unless there's specific history. The second part is why you think that age is the most important factor. Because interestingly, you showed that those who have hypertension and diabetes is no difference. In fact, I thought that due to aging, the comorbidities of diabetes and hypertension will make it difficult for this patient's acute renal injury to recover. So why you think that, as I understand, age is the most important factor? So why you think so when they don't have even comorbidities?
Because with the age, there is a atherosclerotic changes. The renal function with the age also get compromised. And with the comorbid conditions, there will be renal damage subsequently. But in our study, we didn't find that the diabetes or hypertension are impacting when patient is presenting with the acute symptoms, with not having any prior status of the renal disease.
You said female were more in your study than
Yes,
male. Suppose a young female comes with anuria who is pregnant, how would you manage? If a young female who is pregnant has developed anuria with pain, how would you manage?
Sir, first we'll like to know what is the cause of anuria. So for that,
So how would you know?
first we'll evaluate with the blood chemistry, imaging, that is sonography basically. So
Sonography shows that the left kidney is little hydronephrotic. But in pregnancy, sometimes you do see a hydronephrosis, bilateral, because of the uterus pressing on the ureter.
Unilateral hydronephrosis should not cause anuria in a lady. So we should also evaluate patient before intervening. So cause of anuria, why? Whether she is dehydrated, whether she having.
When you did it, you found it, patient has got a single kidney and that is hydronephrotic and she is pregnant.
So depending upon the gestation of the patient, will
4 months.
So we'll explain the patient about the risk of the renal damage, loss of pregnancy, risk to her life. Depending upon that, if patient is fit for surgery, then we would like to put a DJ stent to relieve the obstruction. Or if patient is not
But you
fit
do
for
not
the
know.
surgery, then
When
we'll
you
like
put
to-
a DJ stent, you have to do imaging
Yeah.
and she is pregnant. You will
USG
like to
guided.
do the fluoroscopy on this patient.
No sir, USG guided.
USG guided DJ stenting?
Yes sir. We do USG guided here.
USG guided?
Yes sir. Intra we do USG. On USG we visualize the glide wire in the pelvic calyceal system.
But then you do not know anything about the ureter. Ureter would not be seen on the USG. But you see dilated kidney. You can do a PCN.
If patient is not permissible for the surgery, then we'll put a PCN. Because patient has to continue with the PCN for next 5 months again. So she has to be delayed. If PJ stenting is not permissible in patient, or patient is ill, then we'll prefer the PCN to be used.
Well, when you have an anuria, there is a lots of pressure of the urine on the stone or whatever obstruction is there. Then maybe edema. If you try to do a DJ, there is a very good chance of perforating the ureter and guide wire going out and things like that. You do a PCN, the pressure goes away. And then to do straight without the fluoroscopy, the ureteroscopy. Without a fluoroscopy, you can do ureteroscopy.
The issues are patient will have also patient has to carry with their PCN. That is, carrying a PCN is also painful. As patient is already gravid, she having a difficulty.
Saving through life is more important.
Yes.
Yes, I think your point is very taken. But this another thought process that
Yes.
you have to see, that many times we find it is easy, but stenting may not be possible.
Yes.
So you have to be aware of that fact. If it goes in easily, it's okay. But otherwise, don't waste time and do PCN. That's the message
Yes.
which is being given. Good.
Thank you.
I call upon Dr. Karthik to make the next presentation, urosepsis following uro procedures for urinary access.
A very good morning to the judges, good morning to the chairpersons and dignitaries on and off the stage. I am Dr. Karthik, I am the second year resident in Department of Urology, Goa Medical College, and here we present to you a study titled Urosepsis following urological procedures for calculus disease with preoperatively treated urinary tract infection. Urosepsis accounts for approximately 25% of all sepsis cases. This infection can be either community acquired or nosocomial. Early diagnosis is key for goal-directed therapy, and the goal here is to decrease the overall morbidity, minimize hospital stay, and improve the quality of life of the patient. The aim of this study was to analyze the incidence, risk factors, disease severity of urosepsis in patients following elective urological procedures for calculus disease with preoperatively treated urinary tract infection. So out of the 210 patients which had a history of urinary tract infections treated successfully, we analyzed, and these patients were for a period of 1 year. All these patients were successfully treated with antibiotics prior to the surgical procedure. So out of the 210 patients which we analyzed, 42 underwent ureteroscopy, 8 patients underwent PCNL, 34 patients underwent cystolithotrity, 96 patients underwent ESWL, 10 patients underwent open renal surgeries, 2 patients underwent ureterolithotomy, and 18 patients underwent cystolithotomy. So the urosepsis with all its spectrum was defined as per the International Surviving Sepsis Guidelines by Farooq Bugwadia, and this was classified as systemic inflammatory response syndrome, sepsis, further severe sepsis, septic shock, and multi-organ dysfunction syndrome. Coming to the results of our study, out of 764 elective urological procedures for calculus disease which we performed at our institute over a period of 1 year, around 210 patients were treated preoperatively for an active urinary tract infection. Once the patient was successfully treated for the infection, these patients were prospectively analyzed, and what we found is around 80 patients developed some form of urosepsis. For example, the 96 patients who had pre-procedural UTI who underwent ESWL later developed sepsis, 30 of them developed sepsis. So these 210 patients which we had analyzed, out of them a large chunk, around almost 130 patients were females. Similar is the results in patients who eventually developed urosepsis. Around 55 patients out of the 80 were females. So urosepsis was further classified according to the severity of the disease. What we found is, out of the 80 patients who developed sepsis, 49 had sepsis, 9 patients further developed severe sepsis, 1 went into septic shock, and 4 developed multi-organ dysfunction syndrome and succumbed to the disease. Based on the culture isolates from the urine sample from these patients, we found that E. coli followed by Klebsiella was one of the most common causative organisms, and these patients were obviously treated according to their sensitivity to the antibiotics. On further analysis of these patients, out of the 210 patients, what we found that diabetes, mellitus, and renal insufficiency in basically patients in different stages of chronic kidney disease were 2 of the most prominent risk factors in these patients. Out of the 210 patients, we found that 112 patients were diabetics and 38 patients were in different stages of chronic kidney disease. There was 1 patient who was seropositive, and there were 39 patients who were COPD patients who were on steroids. We analyzed the association of diabetes mellitus in patients with urosepsis. We found that out of the 80 patients, 50 patients were diabetics. And this association between diabetes and sepsis was found statistically significant across all procedures. On analyzing the association of renal insufficiency in patients with urosepsis, we found that out of the 80, 20 patients were patients of chronic kidney disease. And out of these 20 patients, over a period of time, 7 developed sepsis, 3 went into septic shock, and 3 went into multi-organ dysfunction syndrome, and there were 3 deaths. Secondary to the multi-organ dysfunction syndrome, the association of renal insufficiency and sepsis was statistically significant. There was also a significant association between renal insufficiency and mortality. The mortality was 15 times more in presence of renal insufficiency, and the risk of mortality increased as the stage of chronic kidney disease advanced. We further divided these patients into patients who presented, who had an active obstruction versus those patients who were non-obstructed. The 114 patients, this is barring the 96 patients who underwent ESWL. Among the 74 non-obstructed patients, 22 developed sepsis. On the contrary, 40 patients were still in obstruction, 28 patients developed sepsis. And this association of sepsis with patients who presented with obstruction was statistically significant. Post-operative urosepsis was 5 times higher in presence of obstruction. On dividing the elective procedures into open or endourological procedures, what we found in our study is that urosepsis was 2 times higher in cases of open procedures. So urosepsis is defined as sepsis secondary to infection of the urogenital tract. Complicated UTI is the commonest precursor for urosepsis, and patients at higher risk seems to be the elderly, diabetics, immunocompromised, and those with chronic kidney disease, especially stage 2, stage 3. On reviewing some of the literature related to our study, we found that there was one study by Allison et al. From Royal Newcastle, Australia, wherein they compared the patient characteristics, preoperative and intraoperative risk factors in this study. What they found is patients at a particularly high risk were the females, diabetics, and those who had undergone prolonged procedures. Another study by Asham Mansoor et al., which was published in the Scientific Reports, found that higher mortality risk among CKD patients was due to uremia, decreased renal clearance leading to leukocyte dysfunction, accumulation of inflammatory cytokines, and the patients with CKD showed higher organ-specific comorbidity scores compared with patients without CKD. One more study by Julian Mazel et al., published at the BMC Nephrology, found that the mortality rate was lower in the non-CKD group than in the CKD group, and that the chronic kidney disease itself appears to be an independent risk factor for death after septic shock. In conclusion, what we found is over 38% of the patients who were preoperatively successfully treated for urinary tract infection, despite that developed urosepsis and related sequelae. Diabetes and renal insufficiency patients are at a higher risk of developing urosepsis, and the mortality is higher in those patients with underlying renal insufficiency and increases as the stage of CKD advances. The incidence of urosepsis is higher in obstructed systems and post-open surgical procedures, and there must be high index of suspicion, and early treatment is key and is a cornerstone for better outcome for these patients. Thank you.
Thank you, Karthik. You said pre-op UTI was treated. Was the culture done before the procedure?
Yes, sir. So what I mean by we successfully treated the UTIs, the culture was sterile before we took the patient for elective procedure.
In your conclusion, you said a prolonged procedure increases the risk of sepsis. Any prolonged procedure increases the risk of post-op sepsis.
That was one of the articles we reviewed.
One of the articles. So in your study, what was the average duration? Do you feel that in your study, the duration also was an important risk factor?
Although not included in the study, what we found is when the procedure goes beyond 45 minutes to 60 minutes, there is the risk of infection significantly increases.
So will you recommend that we stage the procedure if we are getting delayed? Let's say we are doing a ureteroscopy or a PCNL, let's say a steg-on, and I have already taken 2 hours and there is 30-40% of stone still remaining. So do I stage the procedure or do I continue?
Yes, sir. Especially if you stratify these patients before an elective procedure and we know that they are at a higher risk of sepsis later on, it is rather wise to stage the procedure than try and finish it in one sitting.
Thank you.
You have mentioned the number of procedures you have done, but you conclude that the open surgery is associated with more risk of septicemia and further complications.
Yes, sir. The thing is, sir, in our study we found that there was almost 2.8 times more. In our analysis we found that 2.8 times there was a higher risk of these patients going into sepsis. But it is also the fact that patients who we know beforehand that they are going into sepsis, we are going to risk stratify them and it's likely they are going to undergo an open procedure.
What about
that must be the... Yes, sir.
What about ESWL? You think it is safe in the sepsis?
So,
ESWL in sepsis or in patient with an infection,
yes, sir.
what are its chances of going into septicemia?
Yes, sir. I mean, it is not safe. These patients has to be treated for the urinary tract infection first until culture sterile before we plan on giving an ESWL.
I think in my experience, the ESWL is the most risky procedure in presence of sepsis. In open surgery, I mean, there is a chance of spreading the infection in another, but at the same time, you can drain the kidney and wound and everything, and it can reduce. But ESWL, chances that it might happen.
Just 2 points. You said that we wait for a culture to become sterile and then operate. You think that in every patient, is it possible that you will achieve the sterile culture before you do the procedure?
So
because many times, in spite of giving enough antibiotics, you may still not have a sterile culture. So if that is your criteria, is it practically possible in all 100% patients before you do the procedure?
In practice, sir, what we do is we try to achieve a culture sterile for all patients, but if we don't, then we try and admit these patients a week prior, give them a good cover of antibiotics for a week, and then we take them for an elective procedure.
Yeah, so that's the answer, because I don't think anybody can assure that we will have a sterile culture in each and every patient before you do stone surgery. So that's point one. The second is, now from all this learning, have you changed your protocol to reduce the incidence of infection and any change in the antibiotics protocol? Do you have your institution antibiotics protocol because study is excellent, but at the end of the study, can we do something? That's the purpose of the study. So have you changed any protocol of your procedure doing or antibiotics protocol after realizing that, especially with lithotripsy and interestingly cystolithotripsy, these are the 2 cases where I think you have a much higher incidence of infection. So have you changed any protocols?
So when the patient presents to us the first time around with an active urinary tract infection, despite knowing the patient has a vesical calculus, we just try to de-obstruct the system first, treat the patient with enough antibiotics, and until we try and achieve a urine culture, as I said, or else we try to treat the patients for a significant amount of time, around 7 to 10 days with antibiotics, prior to taking this patient for the procedure. In case of elective procedures where we wait for a good 2 to 3 weeks before, when we know that there has been an incidence of infection, before we take these patients for an elective procedure, so as to decrease the overall chances of sepsis. So yeah, so we try and cover the patient adequately with antibiotics before we plan and take these patients for an elective procedure.
It will be interesting to have a next study based on this, that because of this we change certain protocols, as is very rightly said, the time frame, type of, and then whether you can reduce the incidence of infection. I think that will be a more interesting study. Thank you very much.
One last question. Here. A nice study. None of these cultures had shown any fungal growth, because I think in clinical practice in immunocompromised patients, diabetics, one of the reasons why these UTIs don't subside is because there is an associated fungal growth. The microbiologist has to be specifically asked to look for it, because if it is not treated, then patient will still be in sepsis. You may have a negative bacterial culture. None of the patients had any fungal growth.
None of these patients which we analyzed had that fungal infection, but usually what we do in practice here is despite long-term antibiotics, if the patient is not coming off infection, that is one thing we do investigate, especially in diabetics and patients who are immunocompromised. We do send fungal cultures at outpatients level or inpatients level and try and treat that as well. But in none of these patients we found fungal infection.
And I think when patient is in urosepsis, apart from antibiotics, antifungals have to be started anyways, like whether the culture is positive or not.
Cystolithotripsy, one of the major reasons why patients develop urosepsis after your procedure is because there is high pressures inside the system whenever you are operating. So one of the things you could do for the cystolithotripsy is put an SPC while doing the procedure and leave it inside for some time. So that would be the next study for you. Okay?
Yes, ma'am.
Especially bigger stone if you are taking a much longer time.
Thank you, sir.
Thank you. Good.
The next speaker is Dr. Ekansh Gupta. He will be speaking on poor compliance in lifestyle modification and its significance in recurrent stone formers with recommendation for improvement.
Good morning, sir. I'll be speaking on the topic poor compliance for lifestyle modifications and its significance in recurrent stone formers. The lifetime risk of urolithiasis in India is calculated to be as high as 20 to 25%. About half of all stone formers have one recurrence in their lifetime. To avoid recurrence, it is important to know the risk associated with recurrence. There are high chances of recurrence of kidney stones irrespective of the treatment. More than 90% of patients will develop another stone within 25 years of the first episode. All stone formers, irrespective of the risk, should follow general preventive measures which include adequate urine dilution, normalization of the dietary habits, and reduction of lifestyle risks. Stone formers at high risk need specific prophylaxis to prevent recurrence. Our aim in this study was to analyze the cause of poor compliance to lifestyle modifications and medical treatment in recurrent stone formers and to give recommendations for improvement. The current study was a cross-sectional descriptive study on 60 patients presenting in the OPD clinics of Goa Medical College with consecutively more than one documented episodes of renal or ureteric stone disease. We excluded high-risk stone formers so as to narrow down our focus on barriers to lifestyle modifications as a reason for recurrent stone formation. Patients who were excluded were those with early onset of urolithiasis, uric acid stones and infection stones, diseases associated with stone formation like hyperparathyroidism and nephrocalcinosis, anatomic anomalies associated with stone formation, and those who were on drugs associated with stone formation. We designed henceforth a questionnaire of 15 elements as per the WHO criteria of compliance, most of them being semi-open-ended and recorded closed-ended answers corresponding to a score of 1, 2, and 3. Our questions were spread across 5 categories, namely socioeconomic factors, patient-related factors, therapy-related factors, health care system-related factors, and disease-related factors. Amongst the 60 individuals who were evaluated, 34 were men, that is 57%. 37% of them had a singular previous attack and were now coming with the second attack of renal colic, while 63% of them reported 2 or more previously documented attacks of ureteric colic. The mean pain score of these patients was 4.6 out of 10 and the mean stone size was 14 mm. The first and foremost socioeconomic factors or demographic factors. Amongst the 60 individuals who were evaluated, 34 were men, as I have described, and this is a reiteration. I'll skip to the next slide. The majority of stone formation, that is 68.4%, were from lower or lower middle strata of the society, as we can see from the bar graph. Amongst these 60 individuals, 80% of patients had studies up to primary or higher secondary level only, that means 8th standard. Then 3/4 of the patients had some lay belief in their mind to explain the causation of stone. These beliefs were like consumption of beer is good for stone formation, consumption of milk causes stone, and in their practice, local remedies in the form of concoction of leaves was the first line of treatment. More than 80% claimed to be recognizing the pain when they suffered from the episode of calculus disease. They consider themselves wise, not less than medical practitioners in clinical diagnosis of stone disease. 55% were enthusiastic to accept the advice regarding lifestyle modifications to prevent stone disease, and this was the best news. And unfortunately, 83% told that they had little or no family support for getting treatment of stone disease. Roughly half of the patients had taken medication for stone disease for more than a month. 60% of the patients told that they got immediate relief after medication when they had the first episode of stone. And barring a few, they also told that they did not notice any adverse reaction to medication which they had taken for treatment of stone disease episode. At the time of the first episode, 2/3 of the patients got treatment at the nearest health center, for example the PHC and CHC, and only 32% could make it to reach a specialty center. And in 57% of the cases, reason for not going to a specialty center was actually the distance or the hesitance to travel because of financial reasons and so on, and between their place and the specialty medical center. Regarding the severity of the first stone episode, more than 50% were treated on OPD basis and 43% did require indoor admission. In this cohort, a comorbid chronic condition like hypertension, diabetes, CAD was found to be present simultaneously in 38% of the patients. All 3 patient-related factors and therapy-related factors were found to be significant, as all the 6 factors studied had no significant p-value. Income level and the level of education were of no significance in the recurrent stone forming. The combination of the following factors were also found to be significant in the recurrent stone former, that is cultural and lay beliefs with a poor modification towards lifestyle modification, patient with poor motivation for lifestyle modification being treated at a peripheral health center, and a patient with poor knowledge of the disease and with the presence of comorbidities. All three patient-related factors and therapy-related factors were found to be significant, as all the 6 factors studied had a significant p-value. Income level and the level of education were of no significance in the recurrent stone former. The combination of the following factors were also found to be significant in the recurrent stone former using a descriptive analysis cross-bar tabulation. Cultural and lay beliefs with a poor modification towards lifestyle modification, patient with a poor motivation for lifestyle modification being treated at a peripheral health center, patient with poor knowledge of the disease and with the presence of comorbidities. The current descriptive study showed that the following characteristics are more likely to be noted in the patients with recurrent stone formation: low socioeconomic status, inclusion of non-vegetarian products in the diet, lack of knowledge and understanding about the disease process, no history of prior lifestyle modifications, inadequate fluid intake, difficult access to medical facilities, mild pain in previous attacks of ureteric colic, higher comorbidity score, and no effect on the activities of daily living or only mild discomfort. The treatment and metaphylaxis of the recurrent stone former presents a pertinent challenge. Patient compliance has an immense influence on the success of the treatment, and it is a decisive factor for preventing stone recurrence. Therapy compliant patients are typically older and have had more treatments, more stone related complaints, and more frequent follow-up visits. These characteristics suggested that patient awareness of the disease might improve compliance. Studies conducted by others in the literature reveal that the patients with kidney stones are highly motivated to prevent recurrence and were more amenable to fluid intake change than to other dietary or pharmaceutical intervention. Fluid intake adequate to maintain urine output in the range of 2 to 2.5 liter is a cornerstone for lifestyle modifications in stone formers. And the patient-related and therapy-related factors were the major factors responsible for poor compliance. When a patient had cultural and lay beliefs or was being treated at a peripheral health center, and these were associated with poor motivation towards lifestyle modification. The association was found to be significant for poor compliance. Finally, poor knowledge of disease was also a significant factor. Our recommendations are the doctor must impart to the patient the knowledge about the disease and not just the knowledge about cure for the disease. The stone clinics by specialists or urologists must be had by way of CME for general practitioners to educate and update them on stone disease. The electronic and print media specifically, which is coming up lately, must be engaged to bring about awareness and change in the cultural and lay beliefs of the society. Thank you so much.
Thank you, Dr. Ekansh.
Thank you.
I have a little doubt. How was this study conducted? Like, you gave them the paper to fill up this thing, then you gave them some lifestyle modification, then you called him back and found out whether he is responsive to the lifestyle. What exactly was done?
Ma'am, I designed a questionnaire using the review of literature, whatever.
That is clear. After that?
Then I designed semi-open-ended questionnaire, and I recorded the whatever in their own vernacular languages, Konkani or Marathi or Hindi, whatever they had to say. And
okay. And how did you gauge for compliance of lifestyle modification?
I beg your pardon, ma'am?
you gave them this, then lifestyle modification, whether they have done or not, how you have gauged for that?
Yes, so I followed them, and then first, and there were two components to this. One, how motivated they are, and second, how much they have incorporated it into it. For example, the advice that I
So there
gave
is-
them in the OPD clinics, I followed them, and
So there has to be another questionnaire for them at the end to fill up whether they followed up the whatever you have told or not. Correct?
correct.
Okay. Yeah. Thank you.
I beg your pardon.
Just to clarify, you have taken all the patients which came to you with the stone into the study.
Recurrent stone formers, sir. More than one episode of ureteric polyp.
Recurrent stone form.
Recurrent stone formers.
What about a single stone occurrence, but with family history? Would you take them in your study?
Sir, I'm delighted by your advice, but I did not include them.
You should say the family history, recurrent stone, and even first time bilateral stone. They are the three, one are the most candidate who are likely to develop a stone again. Not lifetime, but within a very short time. So, family history, recurrent stone, bilateral stone.
Thank you, sir. Thank you, sir.
Exclusion criteria.
Like.
Exclusion criteria. Why you kept uric acid stones in the exclusion criteria? No, it's there. Just give an answer.
Sir, these patients responded quickly to, for example, we have OPDs on Monday, Wednesday, Friday. The Wednesday is the general OPD. Monday and Friday is the OPD. So they responded well to alkaline alkalinization fuel.
Thank you, Dr. Ekan. Since we are running behind schedule, I'll ask the next speaker to take the days. Dr. Mahapatra will be talking about spectrum of prostatic abscesses.
Good morning, everyone. Respected chairperson, teachers, my dear friends. I'm Dr. Toba, first year resident at Goa Medical College, here to present my study on spectrum of prostatic abscesses, a review of 28 cases at Goa Medical College. Prostatic abscess is an infrequent clinical occurrence that may be difficult to diagnose due to its presentation with non-specific symptoms. Its signs and symptoms are highly variable and may be even similar to those of acute bacterial prostatitis without an abscess. The mortality rate of prostatic abscess is reported to be between 3 and 16%, and prostatic abscesses are known to progress to spontaneous fistulas into the urinary bladder, prostatic urethra, rectum, or the perineum. In our study, the most common predisposing factors seen with the prostatic abscess were diabetes mellitus, chronic indwelling catheters, instrumentation, and immunocompromised patients. The aim of this study was to see the spectrum of prostatic abscesses presenting to our college with regards to their clinical features, evaluation, and the management. This was a prospective study of 28 patients who presented to our institute within a span of a year. Diagnosis was made on the basis of a detailed clinical history and physical exam, and routine investigation was carried out, most importantly, ultrasound and CT abdomen. This is a typical picture of a CT showing a hypodense image of in the prostate, most likely suggested of a prostatic abscess. Furthermore, images showing the hypodense collection in the prostate. In our study, we had seen that out of 28 patients, 14 were in the age group of 50 to 60 and 8 were in the age group of more than 60. So more commonly seen in the older age group. It was also seen in this study that the most common symptoms associated with the abscess were lower urinary tract symptoms and fever, followed by suprapubic pain. The risk factors most commonly associated in this study, 22 patients out of 28 had diabetes mellitus, followed by chronic indwelling hepatitis seen in 5 patients out of 28. In this study, 4 patients had present with sepsis. According to this data, it was seen more in the older age group with a significant higher total blood count. In this study, out of 28 patients, 16 had bilateral lobe involvement and 12 had unilateral lobe involvement. The management done for patients in this study, 8 were managed conservatively and 20 patients had a form of surgical intervention. In the conservative group, 8 people were treated who had prosthetic size lesser than 2 centimeters, who were diabetics but who had their glucose under control. 2 out of the 8 patients had good glycemic control, and 6 out of 8 patients were below the 50 years age group. Treatment was mainly based on injectable antibiotics, fluoroquinolones or cephalosporin for at least a week to 10 days, followed by oral antibiotics for 6 weeks. It was followed up with repeat digital rectal exam and a TRUS ultrasound after 2 weeks for follow-up. In the surgically managed patients, which were 20 out of 28, transurethral incision procedure was the main procedure done, followed by transrectal ultrasound-guided aspiration, which was done for 1 patient who had a deranged INR. There were 3 patients who had transurethral incision procedure done, but there were atypical patients that had presented actually with perineal, perianal, and ischiorectal abscess, which were not improving, and on further evaluation were found to have prostate abscess. The most common organism detected in this study was E. coli. The complications seen in this study were mostly stricted urethra seen in 2 patients, incontinence in 2 patients, and retention in 3 patients. In this study, it was worth mentioning an atypical presentation of prostatic abscess. There were mainly patients admitted under surgery for ischiorectal, perianal, and retropubic abscess. They were found not to improve after the incision and drainage procedure. They were further evaluated with CT scan, and it showed the presence of a prostatic abscess. The first case was a case of retropubic abscess where the patient had presented with swelling and pain bilateral inguinal lesion. Incision and drainage was done. They were not improving, so CT showed a prostatic abscess. The other one was a perineal abscess, and the third case was an ischiorectal abscess. All these patients were admitted under surgery department of surgery, but followed up with urology. This CT scan showing a picture of a retropubic extension of prostatic abscess, a perineal extension, and a perineal and ischiorectal extension of prostatic abscess. Management was mostly with cystoscopy and transurethral deroofing of the prostatic abscess with adequate open surgical drainage. The Foley's were kept in situ for 1 week postoperatively. Early diagnosis is very important in prostatic abscess because it requires proper treatment. Early antibiotics and drainage can reduce the hospital stay. Once there is a clinical suspicion of prostatic abscess, evaluation should take place either with transrectal ultrasound or CCT to determine the size, number, extent, and the exact location of the abscess to plan for surgical management. It is important to mention that when not adequately treated or if treatment is delayed, prostatic abscess can progress to sepsis. Ki Dong-jang in the Korean Journal of Urology concluded that patients with prostatic abscess treated with transrectal resection had a significantly shorter hospitalization stay compared with needle aspiration. Ackerman L. in the International Journal of Urology showed that majority of patients who had early surgical drainage done, management was mainly through a transrectal approach. Margie Giggle in the Canadian Journal of Urology concluded that transurethral drainage of prostatic abscess is a safe, efficient, and effective treatment option. And treatment option should depend on the abscess size, location, and presence of localization. As mentioned earlier, CT scan is one of the preferred methods of diagnosing, not only diagnosing, but also planning for surgical intervention. In conclusion, most of the prostatic abscesses require transurethral incision of the prostate with deroofing for complete resolution. There will be a subset of patients with small abscesses and controlled glycemia, which can be considered for conservative management. And any abscess in the retropubic perineal region which does not improve or resolve with drainage should be further investigated to allow prostatic abscess. Thank you.
Thank you, Dr. Mahapatra. Questions from the judges?
De-roofing the abscess.
So post-operative, they might have retention due to.
We have removed the prostate and
Yes.
de-roofed it. So there's a big space. And anyway, you're going to give a catheter for a few days.
Yes, post-operative.
Septicemia. Because when you do the de-roofing, because you're putting a fluid, and there is always absorption of the fluid takes place in TURP, normally also. No. That's why the TURP syndrome occurs.
Yes.
And here the septicemia is the organism goes into the
Systemic.
and that's why, of course, as you rightly said, early diagnosis and then transrectal aspiration and installation of antibiotic.
Yes.
That you may have to do little repetitively every two weeks or 3 weeks.
Yes.
But let's settle down.
Thanks.